Normally we would get like 9 hours to talk about all the cardiology stuff, but today we've got 3. So it's a bit of a shortcut, and I appreciate that not everyone's been through all the rhythm recognition stuff so far. So I'll try to come up with a way of sort of simplifying the common supraventricular tachycardias that we look at. And I guess the focus for that is because these are the ones that will appear in the CPGs. So this is not the end all and be all of rhythm interpretation by any stretch of the imagination. It's just the process that we can use to either include or exclude particular rhythm analysis into our management. But anyway, I'll just, maybe if I just start the PowerPoint, you can see it all right?
Yeah.
Okay, so this is a short list, if you like. Just get rid of this out of the way. Of the possibilities that will come with these tachycardias. And so all tachycardias have to have some point in origin, and they've really only got 2 choices. They can either come from above the ventricles, or they can come from the ventricles. And for this lesson, we're just going to be talking about the ones that come from above the ventricles, and we're only going to be talking about tachycardias. So we come down to this list of, I think it's about 7 possible tachycardias that we might be looking at. So we've got this idea that we could either have a sinus tachycardia, or we can have one of these atrial rhythms, or we can have a rhythm that comes from the AV node, or probably least likely of all as a rhythm that comes from the junctional tissue. And it's just sort of fortunate, somebody's here. It's just fortunate that we can even reduce this list a little bit further. And the first thing, although we need to be able to recognize sinus tachycardia, is that in recognizing, knowing that it's a physiological rhythm, so that's like a normal rhythm. It doesn't come because something's gone wrong with the heart. From a structural point of view, it's normally a compensatory mechanism. So someone might be shocked or have some form of sympathetic stimulation, and that's what gives them a sinus tachycardia. So we never treat sinus tachycardia by like giving an arrhythmic for an antiarrhythmic drug. We always try to treat the underlying cause. And then we've got these ones that come from the atria, and I guess again, from a simplification point of view, the one that we're most likely to see is going to be atrial fibrillation, because it's the one that's more common in our population. So like 10% of the population that's over 60 or 65 years old will have atrial fibrillation, and that trebles by the time you get to maybe 80 years of age. So that's something we're going to see relatively often. And the 2 down the bottom for the atria thing is that one that I've called PAT, which is a paroxysmal atrial tachycardia, and it's relatively rare, and it's not too difficult to pick. And then we have a multifocal atrial tachycardia. I'll come back to some of these points, but again, it's not a particularly common rhythm, and it's a startlingly easy rhythm to pick. So we won't have to go too deeply in that. Then we've got these rhythms that'll come from the AV node, and the most common type of tachycardia that comes from the AV node is a re-entry tachycardia, and it's the one that we call the paroxysmal supraventricular tachycardia, and we'll go into recognition of that. But we're not left with many other options. So once we recognize that, we pretty much know where it comes from. And as I said, junctional rhythms tend not to be particularly fast tachycardias. We can get an accelerated junctional tachycardia, but if it reaches a rate of 100, it's doing pretty well. So in terms of clinical presentation, it's not one that we see often. So anyway, but here's our likely suspects that we're going to be dealing with when we look at these tachycardias that occur above the ventricles. And from there, we can go to even a shorter list. So if we were job interviewing these tachycardias, these are the 3 that we're most likely to end up settling on. So we've got this idea that all these tachycardias, if they start above the ventricles, are probably going to have a narrow QRS. And when I say probably, we're talking about a greater than 90% likelihood. In fact, it's probably pretty close to a 95% likelihood that if 100% likelihood if it's a narrow complex QRS and it's above a rate of 100, it's going to be a tachycardia that's occurring above the level of the ventricles. And so our next determination is really just to see whether the rhythm that we can see on the rhythm strip is a regular rhythm or it's an irregular rhythm. And I'm not too sure, and just unmute and jump in. Do you have a method that you use to find out whether it's regular or not?
Me, yeah, just it's probably not textbook, but just doing the big squares between like an R and R.
Right.
And then just seeing how many, like sometimes you'll have them regularly, so they're all like 2 blocks, or some will be be regular irregulars, which, you know, you'll get some that are the same and some that are the others, and then they go through they do that, and then they normalize, and then they do that again, and then the irregular where they're all different.
Right. Oh, well, you've covered all my bases then. Because that's pretty much what I do. My go-to method is to count the squares and see if that repeats regularly or not. And my double check for that is just to get another piece of rhythm strip, turn it over, so I'm dealing with the blank side, mark off the R to R intervals with my partner's pen, because I can never find my own.
Yeah.
And then match it up to the rhythm strip that I'm looking at, sort of thing. Yeah. So it's good because you've covered the 3 options that we can look at. So I know that my short list is supraventricular tachycardia, which is my regular rhythm. So if there's no P wave associated with that and I've got a regular rhythm, I know that it's going to be a supraventricular tachycardia. It's the last thing left on my list. Everything else is going to have a P wave on it. So it makes picking the SVT relatively easy. And then on the other hand, if I go right to the other side of the slide and look at that R to R interval, which is totally unpredictable, then again, the absence of P waves tells me that I'm going to have atrial fibrillation or multifocal. If it's an absent P wave, it can only be atrial fibrillation. That's it. And we've got a couple that will fall in between. They'll be kind of predictable, but they're still irregular. And that's when I start thinking about my atrial flutter as a possible solution. But we will go into it a bit more deeply. So, and my game plan for doing this, I'm sorry if I'm just dragging over what you've already had to endure in year 1 and things like that, but I just can't emphasize enough that if you don't have these 5 bits of information worked out, then you're always putting your interpretation of a rhythm at risk, just by basically not playing with a full deck. The way I look at this stuff here is that the regularity and the rate are really good differentiating factors. You know, if I just go back to the previous slide, I mean, it's this regularity, and particularly whether it's predictable or not, that will automatically alert us to whether we're dealing with atrial fibrillation or not. So it can be a really great differentiating factor when we're trying to come to a decision. The rate is pretty much works in the same way. It's also very good for differentiating. We use it in other ways as well, like it might help us work out the severity of the problem, but because each individual type of cardiac tissue has its own properties in terms of pacemaking, whether it be normal or abnormal pacemaking, rates can help us determine where a rhythm is generated from. And so we know, for instance, that junctional tissue doesn't have a particularly fast intrinsic firing rate. And even when it's producing tachycardias, it struggles to produce fast rates. So we know that the slower, what we'd call an accelerated rhythm as opposed to a tachycardia, is more likely to come from a lower pacemaker and center. Where when we see atrial tachycardias, you know, quite often we're likely to see faster tachycardias, ones that rate up around about 116. And the last thing is around the AV node, where we get the re-entry tachycardias, which is a slightly different kettle of fish, but they're the really, really fast ones. They're the ones that can just look like a green band across the screen because the rates can be faster than 200. So again, the regularity and the rate, really, really good differentiating factors. The P wave really speaks for itself in terms of, like, if there's a P wave there and it's associated with a QRS, then it pretty much tells us where the origin of this is, and depending on the shape of the P wave will give us some clues to which part of the atria it's coming from. And the big rule with the P wave is lead 2. If it's positive and it's rounded in lead 2, the basic assumption is that it's sinus not in origin. So that's our differentiating factor for sinus rhythm. So a sinus bradycardia, a normal sinus rhythm, or a sinus tachycardia is going to have an upright and a rounded P wave in lead 2. Any other type of P wave, if it's all a bit peaky or pointed, or if it's inverted, tells us it's still likely to be atrial in origin, but not coming from the SA node itself. The PR interval, also very, very good for differentiation. Often we use it in the setting of heart blocks to work out what sort of heart block is going on, but it can help in some supraventricular tachycardias as well. We don't need to get into the day, fortunately. And the other huge differentiating factor, the one that we put right at the front of this talk, was that we're talking about narrow complex QRSs. So being able to differentiate in that the QRS is either less than 0.12 of a second, or 3 squares, or greater than that, makes a huge difference to how we're going to interpret a rhythm. Any questions so far, guys?
The first part I can just watch, like, in the recording, eh?
Yes, you've missed all of about 120 seconds, Ray.
Oh yeah, sweet.
Yeah. So hopefully it won't take up to.
I was thinking, oh my God.
Yeah.
Okay, cool. Thanks.
Okay. Right. Well, I don't think I'll put you into breakout rooms today. I don't think that's going to work.
He's really cool about something, is he?
By ourselves.
Okay, so let's put it into some sort of clinical context. You're sent as an ambulance crew to a 17-year-old woman who's been complaining of palpitations which have lasted for more than half an hour. She's called the ambulance because she now has central chest pain, which in the last 10 minutes has got to 7 out of 10. As you're doing your initial checks, you find out that she has a GCS of 15 and she's a bit anxious. And when you put the pulse oximeter on, she's saturating at 94%, and it says her heart rate is 200. So what would you like to do?
Well, so we have to go through our 5 things. We want to see if it's regular, which it looks regular.
Yep.
Quickly.
Yep.
It's like 7 small.
Anything you'd like to do first?
Anything we'd like to do first?
Try and calm her.
A little bit.
Check for dangers.
Yeah.
Oh.
Yeah, dangers.
AJs.
Introduce ourselves.
Okay, so you
Who's whispering? Amanda, you're whispering. What?
You work out that she's alert.
Yeah.
She's fine, but
She's
clearly anxious.
Yes.
And she's told you that she's got 7 out of 10 chest pain. So just thinking back to how we process through scenarios, what can you tell me so far?
And her airway would be clear if we can ask her to swallow.
Yep.
We can see that she's breathing. We do her respirate.
It's 20.
20, and her oxygen saturations are 94%. Okay.
Yeah.
So she's on the cusp, isn't she? But we could, if she's anxious and that, like I said, we try and address that, I suppose, and try and calm her, coach her breathing, maybe, just to help settle that down and see if that makes any difference.
Her heart rate's 200 though.
Her heart rate's 200. So yeah, I mean, that's something that we need to, and if she's got the chest pain as well, we want to deal with the pain as well, don't we?
Yeah.
What do you want to do before we move on with that? It seems that we've got airway and breathing covered.
Yeah.
What's next?
Well, chest pain, we tend to go through the, if you do the CPGs of chest pain, then you give, most of the time we give aspirin, don't we?
Okay, but if we came back to the primary survey and
the primary survey. Sorry, I'm coming through the primary survey.
What's our skin like and our CRT?
What does she look
so
like?
CRT's longer than 2 seconds and she's pale, very, very pale.
Okay.
Yep.
So we want to put her feet up.
Yep.
Put her feet up. So she's obviously peripherally unstable, starting to be. So probably at that rate, yeah.
Was she walking around or she just sitting?
No, she's actually sitting. When you arrived, she was sitting on the ground with her back against the sofa.
Okay. So we'll spin her around, put her feet up on the sofa,
Yep.
lie her on the ground there.
Yeah.
Any change?
No, she still has 7 out of 10 chest pain.
Okay.
But here's a clue: you can now feel her radial pulse.
Okay. So we haven't got a blood pressure, but her blood pressure is coming up a little bit. I'm just sort of mindful of that SpO2 just sitting on 94, especially if she's peripherally slowed.
Why would it be 94?
Well, because we've got the little clip on her finger, so we're not going to get such a good saturation because it's peripherally slowed. So
Brilliant.
Yeah. Put the ear one
put it on the earlobe.
But 94 is still a safe limit.
Yeah.
You know, so yeah.
Yeah, just keep a close eye on it.
Yeah.
See if it goes anywhere.
All right.
Obviously, her pain is going to be another thing because if she's got 7 out of 10 pain, this could be contributing to everything as well.
Yep.
So
what do you want to do? We've got a lying down now.
Yeah.
So what are you going to prioritize? So no oxygen, but we've got her feet up.
Yeah.
And obviously, because I've put the slide up, someone's made the excellent decision to, because the heart rate says 200, to put a cardiac monitor on.
Yes.
It's a bit of a focused assessment, and this is what you can see.
ECG on. Yeah.
Yeah.
Blood pressure.
12 ECG.
65 over 45.
Okay. Whoa, that's not good. Okay. So we're obviously not giving GTN for any chest pain.
And we're calling for backup.
Yeah.
Can we just
What's her? Oh, yeah.
have a look at? We've got a low blood pressure. Yeah. So determine severity. Is that in the CPGs is one of the first things we should do?
Yeah. Definitely thinking this is a big sick.
Big sick. I'm going to CPGs
At the moment.
How much does she weigh? Is she a bit of a porker or no?
No, she's an athletic looking 17-year-old. I mean, we might think that she probably looks in the 65k range.
65k, okay. I shouldn't say that, sorry.
Okay.
It's all right. It's not like it's being recorded, Ray.
Okay, but her level of consciousness is 15, isn't it?
She's GC, yes, she's alert and orientated, yes.
Okay, so I'm sort of coming under, I think, moderately compromised at the moment because they said abnormal vital signs, hypertension, prolonged CRT. It says altered level of consciousness but can obey commands, moderate shortness of breath, significant symptoms of myocardial ischemia, look status 2.
Cool.
What would severe be, Julia? Just I'm thinking with that's a severely abnormal blood pressure and the fact we didn't have a radial pulse.
No, that's true. So severely is markedly abnormal, inability to obey commands. So I suppose the severe hypotension fits into there, but she's still able to obey commands, severe shortness of breath. So sort of on the cusp, because that one sneaks into the hypertension, I suppose, sneaks into that severely. Yeah.
And our CRT and our fact that we didn't have a radial pulse until we lay her down.
Yeah.
And put her feet up.
Yeah.
So how long has that been? And her heart rate's still 200.
What are we seeing on the ECG?
Well,
Oh.
it was,
Count it.
yeah, it's basically regular. The rate,
We know it's 200.
200. Yeah.
200. Yep. So we're sort of thinking,
No P wave.
and it's a narrow QRS. So we're thinking it's above, it's coming from the atria, not the ventricles.
Yep.
We're looking at the P wave, and it's sort of, you could possibly see a P wave hidden there, but it's not
I
obvious.
thought there was nothing.
Yeah, it's not obvious. So possibly because it's too fast. So we're unsure. So I think if you're unsure, you just go to SVT, don't you?
SVT, narrow
At that
QRS.
rate,
Yep.
with narrow
No
QRS,
P-wave.
can't see a P. Can't see a P
Tachycardic.
wave.
Yep. I agree with, yeah, so going by the notes that we just had from Don, no P waves, narrow QRS, narrow complex. So yeah, QRS is 3 squares or greater. Hang on. No, it's not. SVT, severe.
Well, I don't
So
think you call
we're going down.
SVT a severe or a non-severe SVT. It's certainly a fast SVT.
Yeah.
Do we think it's responsible for her symptoms?
Yes, because we're not getting enough time for ventricular filling, possibly because it's so fast.
Yep.
So she's not getting the cardiac output, so therefore she's
Not getting the
node
oxygen.
and that sort of thing.
All right.
We can't rule out anything, other things, but that's one thing that we would look at just to see. And
Well,
also the
here's
pain.
exactly what we should do is start ruling other things out.
I was
So
gonna
we've
say.
got a likely diagnosis. So we probably
Yeah.
need to talk about some differentials.
Yes.
So we're sort of saying basically by elimination, we've come to this thing that we're in SVT.
Yeah.
Yeah.
All right. So, and you've moved to your
SVT thing.
procedures.
Yeah.
Yeah. And one of the first things we did was have a look at the severity table.
Yeah.
And we're somewhere between moderately and severely compromised, and we're leaning toward, which one would we lean more towards?
Oh, look, severe, just to be on the safe side.
Okay. For me, there's a bit of a line in the sand
Yeah.
around this level of consciousness, perhaps.
Yeah.
Maybe the final
Okay.
determination.
Okay.
I like your thinking around that. We can't entirely exclude. I mean, this is quite severe compromise.
Yeah.
Yeah.
But in terms of how we might apply the CPG,
Yes.
we're probably going to have a very close look at this LOC first.
Yeah. Yeah, because that's true. Because in severe, they're saying question mark Valsalva because they can't obey commands. But if she can obey commands, then you could possibly do the Valsalva maneuver.
Right. Okay, good thinking. And then so our last job is, because this person's not in cardiac arrest, because they are not severely compromised and failing and stuff. I mean, we're keeping a close eye on them. I will agree to that. So the next thing is that we just think about our differentials for a narrow complex tachycardia that's regular. So number one, were you 100% sure that was a regular rhythm?
Oh, yes. Where were you? 100%. Sure. Yeah. I was.
Good on
For
you,
the number
Rowan.
of-
So
Holding
just
it up,
when I'm asking these questions, all I'm asking you to do is just to review your evidence.
Yeah.
Yeah.
Yeah. Pretty sure it was pretty clear, regular.
All right. And you're right in this case, because when I counted up, there was just this very steady 7 little boxes
Yeah.
between each of the
Yeah.
R to R's.
Yeah.
So, and if it was a paroxysmal atrial tachycardia, we would see probably a very peaky T wave associated with it. And if it was sinus, we know we would have an upright, rounded, positive P wave in lead 2.
Yeah.
And we know that rates much above 160 become relatively rare with sinus tachycardia.
Yeah.
But when I look at that paroxysmal SVT, rates between 160 and 240 are expectations.
Yeah.
So while I can't completely and 100%, particularly with just a 3 lead ECG,
Yeah.
exclude the others, I can favour one diagnosis over another.
Yeah.
Right.
Proximal.
And it was a sudden onset, wasn't it? Relatively.
Nice.
Yeah.
Brilliant. Yes.
Okay.
So what are we going to do?
17.
Well, we need to back up for ICP because she's moderately or severe. So we need the backup from the ICP.
If they fail to revert after our first Valsalva,
Okay.
just looking at the yellow box.
So we want to try a Valsalva.
All right. So it's the awkward thing, isn't it?
So,
Well, she can spin around and lie on her back, so, you know, and put her feet up.
yeah.
So, this 17-year-old, can you stand up?
Yeah.
Okay, well, that's not going to work, is it?
No. So
how are you going to do it?
well, she's at the moment she's lying on the floor with her feet up, isn't she?
Yep.
So we want to sit her up again with her feet lying flat on the floor. We've got our blood pressure cuff on, our 12 lead on, our little SpO2, so we're keeping an eye on everything. So get a syringe, 20 ml syringe, and explain the thing. Explain it to her. Yeah, explain it to her, and just get her consent and see if feels she's up to attempting the Valsalvic manoeuvre. And yeah, just explain it to her. So blowing for 20 to 30, how many seconds? 20 seconds?
15 to 20
15
seconds.
to 20 seconds.
Yeah.
Blowing as much as she can.
Yeah.
And then after that, we one of us have got her back and one of her legs, and we help lie her down with her legs up and see if it works.
Yep.
Time out, time out, time out.
Yeah.
Got to push print.
Push print on
Push
the
print.
at the start before you do it. So you're printing through the 20
when they start
so
blowing.
when she starts blowing on the syringe, or just before she starts blowing on the syringe.
Oh, excellent. Cool.
Because you will, if you do revert, you'll get some really funky rhythms come through.
Don't want to miss that.
Great for the scrapbook.
Oh, and for the sphincter.
So when you're doing this, because you're allowed to repeat once, aren't you? So how long do you know? I mean, do they, if they're going to revert, is it relatively just immediate? Quickly. And then sometimes they can pop back. So sort of what's the timeline between them if they're going to pop back into SVT? Is there like any rough idea that they will, or can be anything?
Yep, great question. If this manoeuvre is going to work, what you normally see is as you raise the legs and get the venous return, you'll see the heart rate start to slow down. And if it's a true paroxysmal SVT, it'll run along at that slower rate for just only a few seconds before it drops back, or might go into a little period of asystole of maybe just a few seconds. And then it will drop back, and you've got about a 2 and 3 out of 3 chance that it'll stay back in the sinus rhythm, which obviously means 1/3 of the time it's likely to revert back to the SVT. But you'll know within seconds. You don't have to wait minutes to find out if you know.
Okay.
Yeah. I don't know if you've had other experiences, Amanda.
No, very, very much similar. So, and one of the questions to ask patients prior to getting them to do a Valsalva manoeuvre is, have they done one before? Has it been successful? If they've ever had to have adenosine, they'll tell you very quickly they don't want that again. So yeah, so they will, try even harder. So but yeah, that's basically my experiences. I like your few seconds of asystole. I think I had something like 15 seconds.
I've certainly had that with the adenosine, and everyone's like starts crowding around the screen, all praying something else is going to start.
How long do you leave it before you freak out?
Oh, for me, about 3 seconds. Spent my whole career training to keep people out of a systole, not to put them into it.
Yeah, it is pretty freaky.
But obviously, it's more of a risk factor when you have adenosine rather than do the Valsalva.
The adenosine has a higher risk factor, but I've never seen anyone stay in a systole. I think technically it could happen, but it never does. But you know how time slows down
when you're doing things.
Yeah.
But that's when you have that printout and you say to someone, "Oh, this happened," and they go, "No, it didn't." You go,
"Yes, it did."
That's why you push print.
So if this is like you were saying, if someone's got a history of it and they might have had like a Valsalva before or adenosine before, what if this has never happened to this? She's never had this before. Does that are there other risk factors involved with setting her off into SVT or?
No, the big one for me would be misdiagnosis of the rhythm, Julia, not with the procedure itself.
Yeah.
Okay.
So if you had someone who had atrial fibrillation, which is my whole point, that that if you've got someone that's unconscious with this, it doesn't matter what rhythm they're in. It doesn't matter whether it's an SVT, atrial fibrillation, atrial flutter, ventricular tachycardia, because the answer is always going to be the same.
Yeah.
They're going to be zapped, and that's
yeah.
So that's really reassuring to know that once you
yeah.
get down that line, you don't have to make these differentiations. But if we're going to talk about doing Valsalva manoeuvres, and particularly if we're going to be talking about getting people along to help us with adenosine, it's very important to make these differentiations. And hence, if it's an SVT, it's almost a double check of the regularity of the rhythm and whether or not the P wave or any other form of atrial activity is clearly present or not. So that's the big one. And if you're working on the other end of the spectrum, if you're dealing with people who have mild and maybe just moving to moderate symptoms, it's so much more sensible to do a 12 lead before you talk about treatment. So, moderate, well, not moderate, but serious, moving towards that sort of life-threatening end of the spectrum, definitely we would just work off the rhythm strip. But if we had a bit more time and we weren't as confronted with the patient's condition, like the status 3 going on status 2 as opposed to status 2 going on status 1, I would stop and do a 12 lead first. And particularly with the automated interpretation algorithms that are on the ECG, you're probably going to get some more confidence in your own determination as to what the nature of the rhythm was. So it can be very good at picking up the irregular, because like fast AFib can look relatively regular, which is why we ask people to double check it.
Yeah, and that's where we can always use Clinical Desk and send through the 12 lead ECG, so that, understanding that as EMTs, that's not something you're expected to read. So Clinical Desk is a great backup for that.
All right. Well, that was fun.
Fixed her.
Man, I think I've had more visitors in ISO than I have fucking wasn't in ISO.
Typical.
I'm like, what the hell? Anyway.
Okay.
Yes.
What are we looking at this time? And we'll just go with the rhythm this time.
Starting with regularity.
Yeah.
Regular.
I'm getting very irregular
Right.
because it's all very different.
Right.
So if I'll send out this PowerPoint earlier, but if we go back to one of those earlier slides and we talked about a narrow QRS and a regularly irregular, what were our choices?
So regularly irregular is irregularly irregular, which is the irregular narrow QRS with the unpredictable, was coming up AFib,
Yep.
MAT.
Okay. So how can I tell this is not MAT?
Multifocal. Well, can't you see the P waves on the multifocal?
Yes, you can.
Multifocal.
Yes. I'll say that after a couple of beers.
Oh, well, I can't even say it without a beer. So I think you can see the different shapes of P waves or something, can't you, with an MA2, like different
Right.
shapes.
But here we just have the pure F or the fibrillation wave.
Yeah.
As opposed to a clearly identifiable P wave. And the MAT is always easy to pick because number one, there's P waves. And the second thing is that some of the P waves will be different shape than others, but there'll still be a clear P interval associated with them. And we can't say that for this rhythm.
Sorry,
for atrial fibrillation. So that's good. Let me just find the screen again. Oops. Okay. I just had a couple of things to note in terms of clinical pearls when you're dealing with atrial fibrillation. I mean, a lot of people have atrial fibrillation, and most people that have it as a chronic finding are in a controlled state. And when they talk about whether it's controlled or uncontrolled, they're really talking about the ventricular rhythm. So the defining line in the sand is if the rate is under 100, it would be normally considered to be controlled. If the rate's over 100, it's determined to be uncontrolled. And when we describe atrial fibrillation to other health professionals, let's say you're on the phone to someone at the ED or clinical desk, we would always describe atrial fibrillation and the ventricular rate as part of the analysis of the rhythm. So I'd never just say, oh, the patient's in AFib. I'd always say, oh, the patient's in AFib with a ventricular rate of, and then whatever it is. So just to keep people in that loop. New onset atrial fibrillation. So if the patient's unaware that they've had atrial fibrillation or they know that they've never had it before, it's an automatic referral for ED in the strongest of possible terms. That we would make this recommendation, and that's based on the risk profile for pulmonary embolus or CVA as a result of new onset atrial fibrillation. And if you're going to someone who you think might be having a CVA, it's also a good time to set up cardiac monitoring as part of just the overall management of the CVA to see whether or not atrial fibrillation is one of the contributing factors or not.
Just a thought process on that. So if it's a new onset of atrial fibrillation and they're not on any blood thinners, even if they don't have chest pain, which is probably, would you prophylactically give them aspirin? It's not really in these CPGs though, is it?
It's not in the ECGs, and I wouldn't say there's any harm in people giving aspirin. I mean, certainly if they weren't presenting with any other, like if there was a neurological symptom, obviously I wouldn't. But yeah, I'm not sure. The thing with the aspirin really is it doesn't do the job that we need it to do. What we're trying to do is stop thrombus formation. Yeah, where, you know, like the antiplatelets won't ever do that. They just stop stuff from sticking to it. So I don't know, Amanda, you got any thoughts? I'm a bit sort of torn between what the CPGs say to do and the inference of not doing it because it isn't in the CPG.
Yeah, I probably wouldn't, but I'm a cautious wee person. And yeah, if it's not indicated, then probably not. The last new onset of rapid AF I went to was a 23-year-old. So.
Oh wow.
Okay. So yeah, so and we didn't consider aspirin as a treatment. She had palpitations, but not chest pain, and a watch that told her what her heart rate was. And when she googled it, they said call an ambulance, and she was dead right. So it's not always, you know, the older populations and that. So I would not give aspirin, but that's just my.
The other thing that I just wanted to mention quickly around atrial fibrillation is that although the ventricular fast rate, the ventricular, we got an uncontrolled ventricular rate, you can have the same problem that you were describing with the SVT. This is sort of compounded in this case because you don't have adequate, or you don't have any atrial systole sort of helping the ventricles along at all. But generally speaking, when we see symptomatic patients, we see them because they've got other structural heart disease or other ischemic heart disease as well. And possibly one of the more common things that we will see is the onset of left ventricular failure associated with the atrial fibrillation. But moving along. So here's my differential process for an irregular tachycardia when it's a narrow QRS. So I've got a chance of it being atrial fibrillation, atrial flutter, or again, these multifocal atrial tachycardias. And so the differentiating features for the AFib are the presence of F waves and no discernible or predictable PRI associated with it, where if it was a multifocal atrial tachycardia, I'm more likely to be able to see the altering morphology of the P waves and be able to see that there's still a clear PRI, although there may be minor variances in it, it'll still be an identifiable PRI. And we're kind of running out of time, so I'm just going to blast through this one. But the clear one on this is the sawtooth pattern.
Yeah.
So we're probably looking at atrial flutter. A misdiagnosis between atrial flutter and atrial fibrillation is not a massive issue. Not like, well, it's nowhere near as sort of say, it doesn't have the implications that say misdiagnosing an SVT and an atrial fibrillation have. So generally speaking, most clinicians consider atrial flutter to be on the same continuum as atrial fibrillation, and normally people with atrial flutter, if it's left unattended long enough, will actually end up with atrial fibrillation, and the two rhythms can actually toggle back and forth in one clinical presentation. And just having a look at, I don't know if you can see my cursor moving here, yeah. But obviously where we've got these shorter R to R intervals here, we have a 2-to-1. So that's one sawtooth peak there. That's one next to it. So this one here, so it's a 2-to-1 conduction. The following one here is 1, 2, 3, 3-to-1 conduction. And obviously these longer ones, we've got 1, 2, 3, yeah, 4-to-1 conduction. So we've got the whole gambit of what would normally be seen. But the problem, if we have a problem with atrial flutter in a clinical sense in terms of dealing with ill patients, it's normally because they're in a 2-to-1. It is possible for patients to be in a 1-to-1, but it's really, really rare. And you'd have to be a guru to pick it, because normally the sawtooth pattern won't be particularly obvious when it's 1-to-1. You sort of really need that 2-to-1 to get the appearance sort of going.
Oh, so it's sort of more, it's worse when it's 2-to-1 as opposed to 4-to-1.
Generally speaking, because if it's 4-to-1, we can see here, if we look at the cardiac rate here, it's 300, 150, 100. It's almost down to 75 beats a minute across here. Where up here, we're talking about rates of greater than 150.
Yeah.
So if it was a consistent 2-to-1, that's starting to get up there.
Oh, yeah.
And because atrial flutter tends to be secondary to other structural changes in the heart, there's a good chance that those sort of faster rates are going to cause issues. So, and I realise I'm going to start running Amanda out of time in about another 3 or 4 minutes. So,
it's okay. Go through it, Don.
Is that it's exactly the same process. So my first thing that I have to do when I'm thinking about someone who appears compromised and I'm thinking atrial fibrillation and atrial flutter is just to come back on the section of the CPG and have it very, very clear in my head where I think the patient sits on the scale here, because it's going to, regardless of what the rhythm is, it's still going to determine what's going to happen. And when I'm in this severely compromised area and it's characterized by this inability to obey commands or other things that are the gross changes in a person's GCS, then I don't really have to worry about double checking the genesis of the rhythm. If I'm pretty sure that it's the rhythm that's causing the problem, it doesn't matter whether it's an SVT, it doesn't matter whether it's atrial fibrillation, it can be ventricular tachycardia, they're all going to receive the same treatment. But if I'm backtracking through these areas here, and I've got someone who's between, more in the moderate or mild thing, then I've got to be very sure that I'm going to apply the right treatment to the right rhythm. I seem to have got lost here somewhere. I'll get back there. Where were we? Around here somewhere, I think. So, having decided there's going to be a particular course of action, my next thing is to just make sure I run back down through my differentials. And the first one, before I even get to this stage, is just double check to make sure I'm dealing with an irregular rhythm, because that's going to be my clue, my main differentiating factor that I'm going to be dealing with atrial fibrillation, and then come back to make sure that I'm dealing with F waves and not some derivation of a P wave with a observable PRI. And having done that, I can then come back to my decision-making chart here. Oops,
You're an SVT.
I am too.
I'm like, well, Silver.
No, it's not This is how I get myself into trouble. It's why
I thought I'd forgotten everything I knew.
Yeah. So the thing with atrial fibrillation, the clinical pearl for me in this is realizing that when we treat people with atrial fibrillation, there's an established risk in doing it, and that is the likelihood of any thrombic event that's already occurred in the atria being dumped out through one of the ventricles and causing either a PE or an SVT. So where I've got these mild to no symptoms, I'm not going to initiate that risk. There's no benefit for the patient in me rushing and giving them amiodarone just on the basis that they've got atrial fibrillation. So if they're not compromised, let's not go down that risk pathway of having a thrombolytic event secondary to the treatment. So it's not until I get to these sort of moderate signs here that I'm going to be thinking I'm going to need an intensive care paramedic to come along and give some amiodarone. So what I'm looking for here, when I go back to up here, is to make sure that I've got signs that are going to make it worthwhile. The patient is moderate, so it's worthwhile that they undergo this risk. And so I'm looking for signs of ischemia and alterations in their vital signs to be able to go ahead and give the amiodarone. Does that make sense? Okay, and again, if we've got these severe and they're marked by these changes in the level of consciousness, then cardioversion. And the good news of its atrial flutter tends to be very amenable to cardioversion, where sometimes with atrial fibrillation, it can take 2, 3, or at times even more attempts to be able to get someone cardioverted. Okay, so if I had to reiterate a couple of things, one is making sure that when we're going through this, that as difficult as it might be on the job and in the heat of the moment, we need to have both the severity, part of the CPGs available to us, as well as the treatment part based on the rhythm. And except for the most severe of cases where we've got altered level of consciousness, we really have to do a double check and run through some sort of differential to make sure that the treatment we're applying is appropriate to the rhythm. So, and the two ways that we can do that, when people are more mildly to moderately compromised, that we would run a 12 lead and we would get some diagnostic confirmation either from the ECG machine and or from the clinical desk. And the second thing is that we can just manually go through and think about those good differentiating factors that can really help, like the irregularity, the unpredictability of AF does make it stand out. So those are the things I'm going to double check. And I've got to have a list in my head of things that it can't be, because one piece of disconfirming evidence can be worth 10 pieces of confirming evidence. It's brilliant. So I know if I can see P waves, it can't be atrial fibrillation, and I've got to go back to one of those other diagnoses.